Thank you and welcome back to Our Town Podcast. Today we are joined by Dr. Sarah with Elak Health. This is a fantastic new business right here in Sacramento, and they really care about the health care of our community. And if you feel that you know anybody that could use her help, it is priced right, and I would definitely reach out to her. This is one of the best things going on right now in healthcare. Hope you enjoy. Well, thank you so much for coming in today. I really appreciate it. Tell me a little bit about yourself and what you do for the community.
My name is Sarah. I'm an advanced clinical pharmacist. I am currently the founder and the CEO of Elak Health. What I do for the community is that I take care of them to make sure that they don't end up in our ERs and hospitals for reasons that shouldn't have got them there.
Nice. And how did you get started?
I have had a very extensive career in healthcare. My husband and I, who's also our co-founder for Elak, we're both pharmacists, different fields of pharmacy, and we've seen pretty much everything, right? From customer service standpoint, from what the patient really needs, from a corporate perspective, from all the holes in the system. And between our expertise and what we saw, plus our parents' journeys in the healthcare and how we saw them as daughters and sons, we figured that it's time to do something different. Our healthcare is getting to be in a crisis. We all know that.
Yeah.
So it's, we can nag for a change all we want, but it's good to be that change. And that's what we decided to start Elak.
Nice. And so what is your unique, selling opportunity, or what's the uniqueness about your healthcare over Kaiser or any of those types of things?
Honestly, first and foremost, it's the heart. It's really healthcare from a compassionate standpoint rather than from a business standpoint. That's the biggest part of that. After that, it's the differentiators, right? What makes us different is that we attend to the patient at the hours of their convenience. That's number one. So we open when healthcare shuts down. We open until 9 p.m. We open on weekends when all the working force cannot get to their appointments because they also work 9 to 5, just like healthcare. Yeah. Then they can have us after hours. That's one thing. The most important thing after that is that we go to the patient's house if it's within our vicinity. I have had patients that have diabetes or irritable bowel syndromes, and when we go, it's eye-opening sitting here, calling someone, trying to treat them, versus actually going to their house, understanding, how are you taking your insulin? Has it been stored in the fridge or in the bathroom cabinet?
Yeah.
What are you eating? What are you snacking on? What's around you? Is the area safe to encourage walking around the area? Or is it different and you don't feel like you should walk around the area? How do I develop that movement program for you, that diet plan for you, medication plan for you? And it's so important that we actually go to the patient, spend an hour there, and then have a comprehensive plan. And then lastly, we actually go with the patient to their hospital visit or to their doctor's visit or to whatever other healthcare visit that they have. So I always tell my patients, imagine going to the doctor and actually taking a doctor with you, right?
Yeah.
You have two doctors. So what happens is, I'm sure you've experienced this. You go to your doctor's appointment. Our physicians are burned out. They're very busy. They have a lot on their plates. And by no fault of their own, their appointments are rushed, right? So your appointment, you go in and it's like 10 minutes, 15 minutes. On average in California, it's about 15.7 minutes right now. That's almost impossible to target everything you want, especially if it's a chronic condition, right? Yeah. If it's diabetes, if it's heart attacks, if it's a stroke, if it's blood pressure. By the time you explain what is going on, the 15 minutes are up, and now there's a line waiting for the doctor. So what happens is we see the patients before the doctor's visit, have a plan, right? And if they are our long-standing patients, then we already know them so well. So when we go with them to the doctor, as clinical pharmacist, I have the scope to say, hey, these are the medications, that's how they're taking them. These are the labs that would be great if we can order. I would like to check on this lab, for example, because these are the symptoms they've been having. And then from there on, I understand what the physician would want to be doing, right? Like, what is their clinical judgment versus my clinical judgment? And every single time, it never failed, we would come up with the best plan for the patient in about 10 minutes. And everyone is happy, and the physician gets so excited because then someone else will take care of the patient.
Because you're speaking their language.
Yes,
yeah,
exactly.
Yeah.
So imagine the patient in the middle, oh my gosh, this is amazing. Like, right, my doctor and my pharmacist are together in one visit, and I'm getting what I want from the physician in 10 minutes, when normally I would go and be overwhelmed right after.
So you said that you do a house call, essentially. So what is your plan when you go in to do these house calls? What do you set up?
It depends on the patient and what the disease state is. Obviously, I don't just meet them for the first time at the house. Usually we talk with them beforehand. What's going on? Like, fill out the questionnaire. Like, how can I help you? And if it is within our scope, which is chronic conditions, then we set up either, if it's a subscription, then we set up those appointments, or even if it's on demand, it doesn't matter. When I go, I have an idea, or when any of the Elak providers go, we know what we are about to embark on, kind of situation. If it's diabetes mixed with irritable bowel, mixed with blood pressure, I'm going to go with my own blood pressure machine to make sure that theirs is reading like mine, to calibrate, right? Or to make sure it's accurate. I'm going to go check on their insulin supply if they're on insulin. I'm going to go with a pill box if I need to, right? To make sure that if their medications are lying around in bottles and they tend to forget if they took the meds or not, let's get you a pill box and have it morning, afternoon, and figure this out.
The ones that are all dialed in? Yes. Okay, I like it.
And then I have a conversation with them and their family members at the house. Family members are crucial in every patient's healthcare journey.
So when you go, you already have the idea of what you're going into. You come up with a plan. Now, from there, are you setting appointments for them? Are you doing that, or are you having them do all the appointment setting and everything with their primary care physician?
It depends on the patient. Some patients like to have already a communication plan with their physician, so I don't interfere. Some patients give it all to me and to my team. And we can schedule for them, because really what it is that you call the office or the hospital and try to find an appointment for the patient. Or some like to go to their appointments and then bring all that information back and let us know all about it. When and if that happens, we actually send them with questions. Could you please ask these questions in your visit and come back to us with the answers so we can know what to do. Believe it or not, patients that have multiple providers, like they have a nephrologist and a cardiologist and a primary care, most of the time these entities are not talking to each other. And that's what we're here for. So the patient doesn't get confused in the middle.
Now, with the state of our healthcare and people not eating properly, not exercising, not doing those types of things, are you putting them on some of that too?
Absolutely.
Is there an education part of this as well?
100%. It actually comes first before the medications. I know pharmacists have the stigma that we like to put meds on everything and everyone.
Here, take this.
But that's not the case.
Okay, good.
No, it's so important to look at what is happening in the patient's life before we just band-aid with more medications. Medications are great, right? I'm a pharmacist. But they also have side effects and they have cost. So let's try to see if there's any non-pharmacological ways, non-medication ways to address this before we put the meds on. Let me give you a story. This is my favorite story. I have a patient that has diabetes, and her blood sugars were very erratic. Like, they could go high one day, low another day. She takes her medications just as told, right? Very adherent. And it took me a couple of hours, 2 1-hour sessions, to identify that it is actually her psychological state. She has some psych disorders that make her behavior change, and when behavior changes, she binges on whatever is at home. So here I am, I could have just band-aided the meds, increased the doses, eventually put her on insulin, but instead, I had to address the psych issues and the antidepressants and the anti-anxiety meds, make sure we have that, stable. Her diabetes fixed itself.
Okay.
Because there is a core reason. So that's what I'm saying. That's what 1-hour sessions, multiple sessions do to the patients. Don't band-aid with meds. Let's figure out what is really happening.
Okay. So this seems so needed right now.
I'd hope so.
When did you get started?
We started about a couple of years ago as baby idea. And now we're here.
Nice. And what kicked you off? What got you going?
Honestly, the catalyst to this whole thing is my dad's journey. I held different positions in different hospital systems. But when my dad got a stroke and I left all things behind and I was the daughter to my dad, my world, I saw the flaws. I saw the things that we all talk about, but we don't necessarily experience. And the idea was there. My husband and I had the idea. We had even been testing it. But that journey became the catalyst to really push it through.
Okay. And along that journey, so what were your corrective measures to help him through that journey? What did you do?
I always say I was there as a daughter. The one thing I took with me was the pharmacist side.
Yeah.
So I took the knowledge with me. I took the medical lingo with me. And I think that has helped a lot. I took all the appointments. I was his clinical advocate, right? I went to his doctor's appointments. I scheduled his appointments. I did everything I do for the patients now, or what Elak does now. The only difference and disadvantage is I'm a pharmacist.
Yeah.
I already knew the things and could talk the talk. How many patients have pharmacists or doctors in their family, right?
Yeah.
So what are the other people doing?
Yeah.
How are they going through it? If I had the hard time going through it as a pharmacist, what are they doing? And that's what was like, okay, I got to do this for other people.
Yeah. Now, are you only looking at it through the lens of the pharmacy end of things? What I mean by that is, are you looking at it if somebody has a hurt back? Are you also able to do that with them too? Or is it just when it comes to meds and stuff like that?
There are two arms of Elak. There's a chronic condition arm, and that's the stronger arm of Elak. And by stronger, I just mean like that's where our focus has been.
Okay.
On. And then there's the acute side. So there has been instances where someone would say, I had extreme diarrhea. My doctor put me on $1,000 medication. And I don't know, this is right, wrong, like what do I do? Is this appropriate or not? And that's when when Elak, me or any other provider would come in.
Yeah.
So this we call an acute arm. But we do have to assess very well, like, is this something we can help with? Or not, because we don't want to do something that we, outside of our scope or comfort zone. And sometimes it's just a matter of like, I have a doctor's appointment. Can you just come with me because my doctor's not hearing me? Great, yes, I will be happy to do that. So that's what Elak is based on. How can we help you have a simpler journey?
Yeah.
Mostly with chronic conditions, because that's the subscription whole model. But if it's acute, we'll be there for it too.
Okay. Now you said you do stay open after people close.
Yes.
After 6 o'clock, right?
Yes.
You're open till 9. Do patients come see you physically at your place of business?
We go see them. The actual business is virtual. It's a virtual model, but with in-person visits to the patient's house. So we reverse the equation.
Okay.
Yeah.
Okay. And you've got to be growing pretty well.
Thankfully.
I mean, it seems like you should be growing really fast. How many people have you brought on?
Oh my gosh. Do you want an exact number? On average, like tens of people. How about that?
Okay.
Yeah, so far. It's been a year that we've been accepting subscriptions and on demand. So by the time people got to know us, now we're at that level.
So do you have like on-demand nurses that go out or?
We're all pharmacists.
Okay.
I am an advocate for pharmacy because I am one.
Yeah.
And we all have the scope. So most people, when they hear a pharmacist, they're hearing or they're imagining the person behind the counter,
just
right? And the outpatient pharmacist. Exactly. And that's not it.
Okay.
There are so many different pharmacist scopes out there, and clinical pharmacists in general have the scope of all things a provider can do, a physician can do, except diagnose. So we can order meds, adjust meds, order labs, interpret labs under certain collaborative agreements with a physician, so that the physician can only diagnose, which is great because that's why physicians love it, because they get to do what they love to do best.
Yeah.
Yeah, like they get to diagnose and have every else be done by the pharmacist.
Yeah.
We can return that joy in medicine for physicians rather than the burdens that they have right now.
Yeah. It's funny because usually they write the prescriptions and then the pharmacist just fills the prescription where you're kind of coming the opposite direction at them.
Correct.
Yeah.
Yes.
That is great.
And it's for physicians too. Don't get me wrong. I am doing all the things. We're doing all the things for the patients. But again, imagine a world where physicians absolutely enjoy seeing every patient, spending the time with them, because they're diagnosing and everyone else will be taking care of the patient in a different and trusted way.
Yeah.
How amazing would that be?
Yeah.
Right now, they're drowning in administrative and clinical burdens, and we're here for it. We are here to alleviate all that.
That's great. So, Elak, right?
Elak, yes.
Where did that name come from?
We are Middle Easterns.
Okay.
I am Egyptian by ethnicity, and my husband is Iraqi, and we're the co-founders of Elak. And Elak in our language means for you.
Nice.
Yes. So we created it for you and the people.
That's awesome. So you said you work with your husband.
Yes.
And how has that been?
It's great.
Okay. Throw things at each other every once in a while.
No, he's amazing. We have boundaries. We decided to establish boundaries, right? Business is business, personal is personal.
Yeah.
We work all the time. We have teams that we also have to address and supervise and all that. But when it comes to our time, it's our time.
Nice.
So that's how we keep it up.
So how do you structure that? What does he do? What do you do?
So I have the title of the CEO of the company, and Rami has the title of the CFO of the company. So all things finances, and everything that deals with that's his arena. He's also a pharmacist, so he's also a provider in Elak. Just like myself, I'm the CEO and I'm also a provider.
Okay.
Yeah.
And then can other pharmacists come on with you? And when they do come on with you, do they still have regular jobs and they just moonlight with this? Is it a second income for them if they do come on with you?
Yeah, for now it is in all transparency, because we don't have the volume to have them let go of whatever else that they're doing.
Yeah.
My goal is in 5 years, I'm going to have an army of full-time pharmacists in every city in California so that we can go to every patient across the state.
Nice.
So that's what we're working towards.
That's what you're.
Yes.
That's awesome. Now, how have you been getting the word out? What is it something that you need for people to get the word out about you?
Definitely word of mouth. Our patients that have been with us have been telling others about us. And social media, that's right, no brainer. We go to a lot of health fair events and we do a lot of public health education and screenings so that those who are not with us at least get to be screened, and we still prevent the ER visits.
Yeah.
So 70%, I think we just came up with the statistics when we did our analysis the other day. 70% of every patient we've encountered at those health fair education screenings had a major clinical intervention right there.
What?
So I know we ran into some patients that were running with crazy high blood pressures and they didn't even know it. We ran into patients with their blood sugars in the 300s, and I was like, okay, what is happening? So we called insulin prescriptions for them on the spot. We ran into some patients that had a mix of psychological disorders plus diabetes, and we had to do a lot of interventions there. So believe me, people need it.
Right there
at the fair, at the table.
Wow.
Yeah.
That's wild. So you're getting out to these things. What else can you do to blow it up?
Lean on you.
Okay.
No, really, it's the speaking engagement. It's just this social media, meeting people where they're at, right? Most people are on Facebook, or most of them are in the health fairs in the communities. We go to churches, so if you know of a community or an avenue that people are needing this, then we go there and we tell them exactly what we do. Here's the challenge. Our healthcare system has been so complex and convoluted for so long that patients lost trust in healthcare.
Yeah.
Right? And the healthcare, that health bond is the strongest bond. Because you know how we say things come and go. Health doesn't come and go. If it goes, it doesn't come back.
Yeah.
So we're running up against that challenge. That's the most crucial challenge we're facing right now. That trust. And I think that's why it's been a little slower until it booms, because it takes a while to tell a patient, I'm going to do all these things for you, and then for them to believe it and see it and experience it. And then they're like, wow, okay, my friend wants to get that done too. Can you do that too? And I'm like, yeah. So that earned trust is pretty much what we're relying on the most.
Okay. Now, what is the area that you're currently servicing? Because you obviously want to be 5 years from now across California. Where's the area of where you're servicing at this moment?
We're super focused in Greater Sacramento right now because of the sheer fact that we live here.
Yeah.
But we do have partners now in Southern California as well.
Okay.
So we have pharmacy partners, we have different community partners across the state, in NorCal and SoCal.
Okay. And do you currently run a pharmacy on top of all this?
No. That's a whole different situation. No, they're not equivalent. No.
Absolutely not. Okay. Okay. Just checking. Just want to.
No.
I don't want a line out the door.
No, we send
you.
our patients to the pharmacy that they prefer to go to, or we send them to one of the pharmacies that we're partnered with if they prefer to change pharmacies.
Okay. And then when it comes to like your expansion, how are you reaching out to other pharmacists to bring them on to start doing these things?
Okay, I know it's not unrealistic, but they actually find us.
Do they really?
Yes.
That's awesome.
Yeah, different things happened. I was at Loma Linda University, for example, as a keynote speaker for one of their annual events, and that's a pool of pharmacists about to graduate there, right? Yeah. North State University and the student program there, right? So they are finding us, and through those pools of pharmacy grads, more pharmacists find us and connections grow. Like you amplify the connections by like tenfold. CSHP, CPHA, all these avenues that we're also part of. Yeah.
Okay. And then, so from here, where do you go? What is your next step in this journey? Where are you taking this to as you're growing? Are you going to be able to start pushing into further and further down California? You going north?
Both.
Both?
Yes. Well, I can't predict the future. All I know is that our mission is to help everyone out there, at least in California, because we're, bound by our license.
Yeah.
But where it is going to go, in exactly what order, I honestly have no idea.
Yeah. Now, can they use their current insurance for you at this moment in time?
Not at this moment. We've been fighting for this, and we just received some good news that it's promising that next year, third-party insurance companies will be reimbursing clinical pharmacists for their clinical services.
Okay.
Because we're short physicians and medical staff, right? So it makes sense that we rise to the challenge and get paid for these services. But not yet. Until that's confirmed, we cannot do that.
Some people have a health savings account, or they have, what is that other thing? It's like where money goes into it, but they can use it for what they want. They can go to a chiropractor. Can they use those types of accounts?
I haven't run into this, but I would venture yes, because I had one of those in the past as well, right? Isn't that like a card that you pay things with?
Yes.
Yeah, so I would assume so, yes.
Okay. Now, if they're paying out on their own, is there a base price? Is there a barrier to entry?
No, there's no barrier to entry. So we meet with the patient virtually for about 15 minutes to address or to assess actually what it is that they need. Some patients need a lot more hand-holding. Okay. And that's okay, right? And some patients just have one chronic condition that doesn't need a lot of their time and my time and their effort and my effort, but they still have, all the unlimited texts and emails that they get to us. So on those 15 minutes, we have packages, for the lack of better terms. So we assess, is this a patient that will need to meet with us once a month? Or is this a patient that in order for us to help them out, they need to meet with us 3 times a month.
Yeah.
Right? And then based on that, we let them know, okay, this is the price, this is the base price. It's $5 a day. That's the base price, right?
Okay.
Based on what I'm seeing, I assume that you are going to need us clinically, obviously all the time, texts and emails, and once a month. If they feel like, no, I'd rather see you 3 times a month, then that's great. And then we adjust the price accordingly. So that's how we evaluate it.
So you said virtually. Are you just jumping on a Zoom call or a Google call or something like that?
Yeah.
Yeah. Dude, that's really cool.
Yeah.
So before you go, do you have them walk around the house with their phone and hey, I want to open up the cupboards or anything like that? See what's in there? What are you eating?
I usually would ask the questions. I wouldn't have them FaceTime me on the spot. But yes, we do all this. We ask the right questions before we go. Yes.
Good. I bought a house like that. I had the person walk around with the phone, and I was like, okay, I'll take it.
Nice. That's awesome. Wish I could do healthcare like this. Maybe one day in the future. You never know.
Exactly. So anyway, now how do they track you down?
Literally everywhere on social media. So it's Elak Health on Facebook or Instagram. My name is Sarah on LinkedIn. YouTube, it's Elak Health. Our website is elakhealth.com. So, and Elak is E-L-A-K because a lot of people misspell that. Okay. And that's how they get me.
Perfect. Yes. Well, thank you so much for coming in.
Thanks for having us.
Awesome having you. I think this is a fantastic idea that you have.
Thank you.
I hope in 5 years you own California.
Yes.
Awesome.
Thank you.